So we all know that pediatric endocrinology is often considered a rare disorder which is complicated, requiring cumbersome workup and exorbitant treatments. And that's why often disorders of pediatric endocrinology are either missed or missed. And there are a lot of issues in terms of pediatric endocrinology that people tend to blame. One people talk about is affordability, that these are very expensive investigations. Doctors are not available, but actually it's the awareness which is the major factor. So if we really empower people, both the pediatricians, the trainees, as well as the general public, they will get to the doctor at the right time and they will identify. That's what we found, that awareness is the key from that regards. In a country like India, where there is a huge burden of pediatric endocrine disorders, we have got very limited number of pediatric endocrinologists which are there. So there is a need to build a pyramidal approach in which we have got referral across board, in which cases are managed and triaged appropriately. And that's why this development of pediatric endocrine resource is extremely important. We have been working over the last 15 years in different aspects of pediatric endocrinology, and we have conducted over 120 workshops, 15 practical courses, two postgraduate programs, and multiple advanced courses across the country. But then what we realized that it was going to be very difficult from that perspective to work off. I'll request everybody to mute themselves, please. So we have been working in different aspects. So we realized that it's going to be very difficult to have physical program across the different parts. So we started off with our YouTube channel, in which we have published a number of videos which are easily available, and a lot of views have been done in that regards. Over the last 8 years, we have had fellowship programs which are there. Now we have 14 fellows till date who are there as part of our program. And many of them will be joining us. Dr. Neha, Dr. Chetan, Dr. Riddhi, Prateek, Manoj, Vibha, Dhwani, Alapan, Nimisha, Riya, all of them will be part of this program. So there are few who are busy who couldn't join, but otherwise most of them will be part of the program. Because it's difficult to have physical fellowship programs for everybody, we started off with MedEClasses, which provides online resources in terms of pediatric endocrinology, including fellowship, diploma, and multiple courses. Our fellowship program is a 2-year program in which we have online and 4 on-site visits with routine assessments and options for research. Till now, 48 people have been awarded fellowships, and 72, and now the numbers have gone up, are continuing that from different parts of the world from that perspective. We've got multiple publications in pediatric endocrinology. Our mobile application, which we'll discuss about, provides a practical way of enhancing pediatric endocrine care. It's the most downloaded endocrinology app across platforms, and it has resulted in multiple publications in that perspective. We are going to launch BIG, which is bone age assisted interpretation of growth, very soon in the next month, which is going to provide direct assessment of growth, puberty, obesity, and multiple parameters on the entry of a few parameters, and you will get interpretation and likely diagnosis and assessment management from that regards. We are also working on developing personalized intelligent nutrition, which is going to guide us in terms of the nutritional requirement, assess meals, and plan based upon intelligent pathway. Our diabetes application is going to provide point of care guidance to insulin dose, glucose, activity, sleep right, and eat in terms of pediatric type 1 diabetes patients. And this is under clinical trials at the moment, and hopefully this is going to change the way diabetes is managed from that perspective. So coming back to this course, this is an extensive course, and this day is to basically dedicated to office endocrinology.
Thank you so much for the kind introduction. I am grateful to Anurag sir and Team Regency for giving me an opportunity to speak at this platform on a topic so dear to my heart. So, sexual differentiation involves a series of complex events whereby sexually undifferentiated gonad and external genitalia serially acquire either male or female characteristics. Now, this depends on your chromosomal makeup and genetics, what gonads are formed, the ability of these gonads to form the required sex hormone, the ability of these hormones to act on their end receptors so that there is differentiation of your internal as well as external genitalia. More importantly, these hormones also play a role at the level of brain to create a perceived gender identity in every individual. An important thing to remember is that your gonads are derived from your urogenital axis, which is also responsible for development of your kidneys and adrenal glands. Therefore, defects in the gonad may be associated with concomitant abnormalities in your kidneys and adrenal glands. Coming to XYDSD, so XYDSDs are due to act of omission. Anything that goes wrong along this pathway of virilization of a boy will result in any omission in this pathway will result in an undervirilized male and an XYDSD. So if you have problem at the level of chromosomes, your gonads, your hormone receptor, any of this can result in XYDSD. Another important hormone, which is although not essential for virilizing a boy, is your anti-Mullerian hormone produced by the Sertoli cells. It comes in very early in fetal period and is responsible for regression of Mullerian structures in an XY individual. So when you have defective AMH levels in an XY individual, you will have persistence of uterus. Whereas most cases of XY-DSD have no uterus due to proper synthesis of AMH hormone. On the other hand, your XX-DSDs are due to acts of commission. So you know your default setting when no other hormone is coming in, your external genitalia will develop into a female. If there is anything coming in which causes virilization of this individual, it will lead to an XX-DSD. This virilizing hormone can either come from your adrenals, which is your most common congenital adrenal hyperplasia. It could come from your gonads, which could be either genetic causes or conditions like aromatase or luteoma. We will be talking about it subsequently. Most importantly, XX-DSD will have Mullerian structures and no gonads. So your DSDs can be broadly classified as XX, 46XX DSD, wherein you have no gonad in presence of Mullerian structures. These are due to androgen excess, either from an adrenal source due to congenital adrenal hyperplasia, or from an ovarian cause, which may be caused by aromatase deficiency or luteoma. You may also have gonadal dysgenesis due to SRY gene insertion, SOX9 defect, or FOXL2 defects in a 46XX individual. Moving on, your 46XY DSDs, you have palpable gonads but no Mullerian structures. So causes of XY-DSD include gonadal dysgenesis due to NR5A1 defect, which is associated with adrenal problems, WT1 associated with concomitant renal abnormalities, or due to SRY gene deletion. XY-DSD may also be due to impaired androgen synthesis or action. So your impaired androgen synthesis is due to proximal defects, which may or may not be associated with concomitant glucocorticoid-mineralocorticoid axis dysregulation, or they may be due to isolated testosterone biosynthetic defects like 17-beta HSD deficiency. Or moving down the pathway, you may have normal testosterone production but impaired DH conversion to DHT, as with your 5-alpha reductase 2 deficiency, or you may have normal production of testosterone and DHT but an impaired receptor action resulting in androgen insensitivity syndrome. Last up, you have sex chromosomal disorders wherein you have both your palpable gonad as well as Mullerian structure. Now, these individuals may have ovarian tissue, testicular tissue, or ovotestes. So, who is DSD and who needs to be evaluated along these lines? If you have an apparent male, a phenotypic male with bilateral cryptorchidism, severe hypospadias, especially penoscrotal hypospadias, or if you have hypospadias with undescended testes or micropenis, then this individual needs to be worked up along lines of DSD. Similarly, if you have an apparent female with inguinal or labial gonads, with labial fusion and an anogenital ratio greater than 0.5, or when you have clitoromegaly more than 1 centimeter, also think of DSD later in life when you have pubertal virilization in a female or primary amenorrhea in a female. Okay. So what all things will you look for on examination? You will look at the phallic length. In an apparent male, if your phallic length is less than 2 centimeters. In an apparent female, if your phallic length is more than 1 centimeter. Palpate for erectile tissue. Look for palpable gonads. They are felt as round rubbery tissue in the inguinoscrotal regions bilaterally. Sometimes, very rarely, it could be fallopian tube, and that is palpated, but usually it is, if you feel a round structure, it is most likely testicular tissue. Look for genital asymmetry. Does the genitalia look, there are instances wherein one side of the genitalia looks like labia and the other side has more rugosities like scrotum. So if you have genital asymmetry, it could be a soft sign that this is an overtesticular DSD. Most importantly, and last but not the least, look for Mullerian structures. They can be palpated digitally, and on digital per rectal examination, they are felt like cord-like structure in the midline anteriorly. But a more convenient option and something that you can easily identify in the neonatal period is with a pelvic ultrasound. Because of the effect of maternal estrogens, in a female fetus, you can easily identify uterus in the early neonatal period, right? And to highlight how important physical examination is, or your clinical examination is, I want to highlight a case that we had encountered at Regency. So we had this international patient who was found to have no palpable gonads, underwent multiple ultrasounds. Some showed doubtful Mullerian structures and some did not show Mullerian structures. Was assumed to be an XX-DSD, started on keeping a high suspicion for CH. The child was started on hydrocortisone, fludrocortisone, and couple of weeks later, the karyotype report came out, which was 46XY. The treating team was confused and requested the family for a repeat karyotype, considering that there was some lab error in the karyotype report, and that is when the family sought consultation with us. At their first visit, we were able to find gonads in bilateral inguinal region. A repeat ultrasound done at our center showed no Mullerian structure. So, what was once believed to be an XX-DSD and treated along those lines, the game completely changed with rightful clinical examination. Eventually, the genetics came out to be 17 beta HSD3 deficiency in this child. So, moving on, clinically, if you have no palpable gonads and Mullerian structures, you are dealing with an XX-DSD. If you have palpable gonads but no Mullerian structure, you are dealing with an XY-DSD. If you have both palpable gonads and Mullerian structures, you are either dealing with an AMH defect or an ovotesticular DSD. And when you have none, no palpable gonads and no Mullerian structures, this could either be an XY-DSD with abdominal gonads, or this could be a case of amenorrhea, wherein your testes was present at some point of time in utero, whereby it produced AMH leading to Mullerian regression. But by the time it was supposed to start producing testosterone, for some reason the gonad involuted. So that is why the child had atypical genitalia. Common endocrine investigations that are done in children with atypical genitalia, the most common is 17 hydroxylase deficiency, 17 hydroxyprogesterone levels, done when you suspect a case of CH, that is no palpable gonad and presence of Mullerian structures. It is important to note that the levels are done beyond 72 hours of life, and levels greater than 100 nanograms per ml. This level is practically diagnostic of 21 hydroxylase deficiency. It is important to use an extracted sample as there may be interference with other adrenal metabolites in the early neonatal period. Next up is DHEAS. DHEAS helps to differentiate children with XY-DSD when you also have concomitant salt wasting. So it helps differentiate more proximal defects like star and side chain cleavage from 3-beta HSD, which will have a high DHEAS level. Next up is your androstenedione level. Again, important when you have an isolated testosterone biosynthetic defect. So your adrenal and mineralocorticoid and glucocorticoid axis are normal. That is when you do androstenedione levels. Like I said, with 17 OHP, you need to do it beyond 72 hours for androstenedione levels, or testosterone DHT levels. Do these levels beyond 7 days. And if you're dealing with a child who is beyond the stage of mini puberty, do HCG stimulated levels. In 17 beta HSD deficiency, you will have accumulation of androstenedione, resulting in testosterone to androstenedione ratio less than 0.8. Next up is your testosterone, helps differentiate between 5-ARD2 and AIS. And last but not the least, next up is dihydrotestosterone levels. Again, testo to DHT ratio greater than 10 will give you a diagnosis of 5-ARD2 deficiency. However, now we know that it is a biochemical diagnosis, and more often we've seen that there is a huge overlap, and genetics is ideally the way to go forward and differentiate 5-ARD2 from androgen insensitivity. Last and most important, I would say, test that is frequently ordered, but you need to understand why it needs to be ordered and when it needs to be ordered, is your anti-Mullerian hormone level. So if you have a child with apparent XY-DSD, that is, you have palpable gonads but no Mullerian structure, you don't really need AMH levels. AMH was present at some point of time, and that is what caused Mullerian regression. That suggests that your AMH levels are sufficient. So you don't need to do AMH in every child with XY-DSD. You need AMH when you have presence of Mullerian structure or when you have abdominal gonad and you cannot palpate it. So it will help differentiate XY-DSD due to an intra-abdominal testis from a child who has anorrhea. Okay. So yes, again, as I mentioned, if you're dealing with a child who is beyond the period of mini puberty, that is LH is less than 0.7 milli-international units per liter, then you go for an HCG stimulation test. There are various protocols. The one that we follow is take basal sample on day 1, followed by HCG stimulation with 5,000 international units per meter square, followed by a repeat sample on day 4 beyond 72 hours, and testo DHT androstenedione levels taken again at baseline and day 4. In children with XX-DSD, if you have very high 17 OHP levels, high DHEAS and normal DOC, you're dealing with 21 hydroxylase deficiency. If your 17 OHP and DHEAS are both high and your DOC is normal, it could be 3-beta HSD deficiency. Very high DOC is diagnostic of 11 DOC deficiency. And POR, again, you can have variable presentation, but it tends to have high 17 OHP and DHEAS levels. In children with XY-DSD, if all metabolites are low, you're dealing with a proximal defect, star or side chain cleavage. If your DHEAS levels are high, it is either 3-beta HSD, POR deficiency, or 17 hydroxylase deficiency. If your DHEAS and androstenedione both are high, that is 17-beta HSD3 deficiency. If you have high testosterone and low DHT, it is probably 5-ARD2 deficiency. And if you have if your all androgen levels are high, it is likely androgen insensitivity syndrome. So this is the algorithm that you need to follow for stepwise evaluation. And just a minute. Yeah. So if you look at the right side of the screen, I'm sorry, I'm not able to use a pointer here. If you have no palpable gonads and you have presence of Mullerian structure, look for maternal virilization. If you do get a history of maternal virilization during pregnancy, you're dealing with aromatase deficiency. If there is no maternal virilization, look at the 17 OHP levels and your electrolyte status. If you have salt wasting, if you have 17 OHP more than 30 nanomoles per liter, regardless of salt wasting, you're dealing with 21 hydroxylase deficiency. Borderline 17 OHP levels between 10 and 30 with salt wasting could still be 21 hydroxylase deficiency, or it could be 3-beta HSD deficiency. With normal electrolytes, you can have simple virilizing form of 21 hydroxylase deficiency. However, if you have mildly elevated 17 OHP and low potassium, then you're dealing with 11 hydroxylase deficiency. If your 17 OHP levels are less than 10, it is most likely gonadal dysgenesis. Moving on to the leftmost side, if you have palpable gonads as well as Mullerian structures, look for genital asymmetry. If you do see asymmetry, this is over testicular DSD. If not, look at the AMH levels. AMH levels more than 10 are suggestive of AMH resistance, and less than 10 suggest gonadal dysgenesis. Now, everything that lies in between is your XY-DSD or anorrhea. So if you have no Mullerian structures, no palpable gonads, do AMH levels. AMH levels less than 10 are practically diagnostic of anorrhea, and doing this will help prevent unnecessary diagnostic laparoscopy in the child. If your AMH is more than 10, that means you have viable intra-abdominal testicular tissue. Go for testosterone levels and electrolyte status. If you have salt wasting, it is star side chain cleavage. If you have low potassium, it is 17 hydroxylase deficiency in the presence of low testosterone, of course. And if you have normal electrolytes with low testosterone, it is isolated steroidogenic defect. Now, this could be because of either 17 beta HSD deficiency, LHCG receptor defect, or several other genetic forms. If you have high testosterone with salt wasting, it could either be it is usually 3 beta HSD deficiency. However, in the absence of salt wasting, look for the testosterone to dihydrotestosterone ratio. More than 10 is suggestive of 5 alpha reductase deficiency, and less than 10 is suggestive of androgen insensitivity.
Towards our discussion point, and we are joined by our panelist, and Nimisha is here. So we will be focusing about the various aspects of the cases. Whatever has been discussed will now be discussed in the form of cases. So over to you, Nimisha.
Good afternoon, everyone. We'll begin with the first case. 14-day-old preterm girl was brought by the parents with the complaint of ambiguous genitalia. The picture is shown here. Dr. Dhwani, ma'am, what will be your approach in this case?
So, in a preterm child, it is very, common to mislabel someone as atypical genitalia. Preterm children have a poorly developed vulvar fat, which makes their clitoris appear more prominent. So, unless there is some posterior fusion, it may not be wise. Similarly, they may also have edema, local edema, which may lead to a perceived clitoromegaly, which may not be a true clitoromegaly. So, if you don't have any other manifestations, it might best be to wait before we investigate along lines of DSD.
So, in this girl, there was no labial fusion, no palpable gonads, and only the labial edema was present. So, there was no need for further workup. Your key messages, ma'am?
Yeah, so again, in a preterm girl child, if you have no palpable gonads, if you have no posterior labial fusion, don't jump to the conclusion of DSD. Give it some time, and it will be more clear whether or not the child needs workup.
Thank you, ma'am. Moving to the next case, 3-month-old girl child with no vaginal opening, no clitoromegaly, and no palpable gonads, with the genitalia picture shown here, was brought to us with ambiguous genitalia complaint. Dr. Varsha, ma'am, your approach in this case?
Yes. Am I audible?
Yes, ma'am.
Okay. Looking at the picture, it is wrongly labeled as DST because under the cover of DST, clitoromegaly is must, or any palpable gonad or AG ratio or more than 0.5, it is must. From the picture, I can realize that it is in some sort of additions. What are the further examination findings?
Yes, ma'am.
So it was labial addition. It is more common in this infantile age group girls because of low estrogen, in which vulva used to fuse, and because of chronic inflammation, it is more commonly seen scenario. So watchful waiting, if it is asymptomatic, is the key.
Yes, ma'am. So there's no need for further workup in this case. And your key messages for this case, ma'am?
That unnecessary labeling of DST should be avoided. Clitoromegaly and palpable gonads are important to consider if we are suspecting DST, and unnecessary workup should be avoided.
Thank you, ma'am. Moving to the next case, 2-month-old boy was brought to us with a concern for DST. There was penile hypospadia. Stretched penile length was 2.8 centimeter. Palpable gonads were there. Dr. Prateek, sir, your opinion on this?
As Dhwani has rightly explained, what we do need to classify what is DSD and what is not DSD. So if you go by the clinical examination, we have a very distal hypospadia. Stretched penile length is 2.8, which is not less than 2.5. and bilateral gonads are present. So to classify someone as a DSD, you need to have either bilateral undescended testes, or a very severe or very proximal hypospadias, or you have undescended testes with micropenis or hypospadias. So in this situation, to prevent unnecessary investigations, there's no need to work up. It's just a very distal hypospadias. Yeah.
Very rightly said, sir. Moving to the next case, 8-year-old boy was presented to the OPD with complaint of small phallic size. Height was 130 centimeter. Weight was on the higher side, 44 kg. Bilateral testes were palpable. They were 2 ml in size. Dr. Yasmin, ma'am, your approach to the case?
Good afternoon. Am I audible?
Yes, ma'am, you are audible.
Okay, thank you. Very nice. Actually, if you look at the age of the boy with weight, then the boy having obesity, right? And when we will get a case of a small phallus, then we have to look for the testes. As you can see in this case, the no cryptorchidism, rather the testicular volume bilateral 2 ml. So we have to search for the syndromic features also. Then we can go for searching either having, oh, it's not having any polydactyly or any visual problem. Then we have to measure the SPL, stress penile properly. As the boy having his SPL 6 centimeter, then if we know that the age more than 5 years old boy having actually more than 4 centimeter is normal. So no need further workup in this case. So we can consider it's as a case of buried penis in obesity.
Yes, ma'am. There was no need for workup and it was a buried penis. Moving to the next case, day 3 child who was brought to us with a concern regarding ambiguous genitalia. It was Prader 4 stage with no gonads. Dr. Dhwani, ma'am, how would you like to approach this case?
Yeah, so again, if you have no palpable gonads, either examine or go for an ultrasound for Mullerian structures. So were the Mullerian structure present or not?
The Mullerian structures were present.
We're dealing with an XX DSD. The next step in this algorithm would be to look at the electrolytes and 17 OHP levels.
Yes, ma'am. So uterus was present and karyotype was done. It was 46XX. There was hyponatremia along with hyperkalemia.
So again, as we can see, hyponatremia, hyperkalemia, and 17 OHP more than 100 nanograms per ml, practically diagnostic of 21-hydroxylase deficiency, the most common form of DSD we encounter in our day-to-day office practice actually.
Yes, ma'am. So the gender of rearing according to you?
Yeah, so again, a very controversial subject, but yes, if you had a lower Prader staging, we would probably counsel the parents more along lines of a female gender of rearing, but with such such degree of virilization, a male gender of rearing would probably be more fitted to the child. But again, it is something we would want to discuss with the family and take the child's child's opinion into consideration as they grow up. And that is how we will be going ahead with the gender of rearing, decision of gender of rearing in this child.
Okay, thank you, ma'am. So this was the case of CAH. The key messages here, ma'am.
So if you have bilateral cryptorchidism in an apparent male, look for, this is again, you work up along lines of DSD, look for presence of Mullerian structures. Timely evaluation in these children is life-saving. With proper treatment, they can lead a normal life. So do pick up them in your OPD as soon as you see these patients. When you're going for 17 OHP levels, do them beyond day 3 of life.
Thank you.
So, Dhwani, when would you like to go for clitoroplasty in this case? And what would be
Clitoroplasty, yeah, so clitoroplasty could be done early, before starting school actually, if the parents are willing. And vaginoplasty could be done later on in life, by the time they're nearing their menstruation.
There are a lot of legal and ethical issues also which have now cropped in. So we need to be very cautious in that regards. And now many states have actually got policies that unless and until you have a proper institutional review board, you don't go ahead with that. So this is becoming very difficult. But this is one scenario where there is no issue as far as the gender of rearing is concerned. We are very clear that it should be a female gender of rearing. but yet we have to adhere to the local guidelines, and hopefully there will be newer guidelines coming up for DSD which will tell us exactly how to approach overall, because many pediatric surgeons are now really not ready to do these cases easily. So that is something which is very important to address.
Thank you, ma'am. Moving to the next case, day 3, child was brought with the concern of DSC. The picture is shown on the right side. With Prader 4 staging, there was no gonads were palpable. Dr. Varsha, ma'am, how will you like to approach this case?
Okay, no gonad. So no gonad, it means either we are dealing with XX DSD or XY DSD with abdominal gonads. I would like to know about the Mullerian structures. Were the Mullerian structure present in this child or not? Uterus and
Ma'am, Mullerian structure was present. Uterus.
oh, okay. And karyotype is 46XX. So either with this scenario, either we are dealing with 21 hydroxylase deficiency or other rare form of CH like 3 beta or POR deficiency, aromatase. I would like to know the history of maternal virilization. Okay, so there was maternal virilization present. So most likely we are dealing with the case of aromatase deficiency as the 17 OHP is less than 30, which is also one of the conclusive of the rare variant, and maternal virilization is a great clue for POR or aromatase deficiency.
Very rightly said, ma'am. Borderline elevated 17 OHP raised the possibility of aromatase deficiency. The gender of rearing according to you, ma'am?
Gender of rearing, it is again controversial, but social, psychological, legal, ethical issues come into the play. But within the 46XX DSE, with this, usually the sex of rearing which should be offered with the consensus would be the female gender of rearing.
I think that's a very, very valid point, and the main determinant as far as gender of rearing in particular the psychosocial sexual orientation is how much androgen was exposed in the given period. So if the androgen is very, very high, let's say bladder stage 4 or 5 of CAH, or some cases, that is the only scenario where you will find gender dysphoria. With aromatase deficiency, you will have a normal female, and this was a child actually who came to us very late. This was one child who came early, but one child came late, diagnosed as CH, managed with the steroids, and then when we saw it was not fitting into CH, then we evaluated and found there was aromatase deficiency. But the big problem there would be that they will have no estrogen production. So they will have again some virilization and puberty, and they will go into premature ovarian insufficiency. So that is a bit of a issue there. Fertility will be an issue.
Thank you, sir. Moving to the next case, day 14 child was brought again with the concern of DSD. Bilateral gonads were palpable here. There was no uterus. The karyotype was done. It was 46XY. Dr. Prateek, sir, your approach to the case?
Yes, absolutely. So as opposed to the case we saw previously that I discussed, we clearly have a DSD over here now. We have a phallic structure, we have bilateral gonads present, and ultrasound, and we have XY and no Mullerian structure. So we are dealing with XY DSD. So this is an undervirilized male, and there has to be a defect in testosterone production. So if you go back to the previous slide, in this, So basically it depends on, we can either have a very proximal defect or a very distal defect. And based on biochemistry, it is easy to know, because as and when you go down the steroidogenic pathway, the metabolites will keep accumulating. So you'll have lower metabolites in a very proximal defect such as STAR or SCC. And as and when you go down to AIS, you will have everything being high. So that is a very good indicator of where we lie in the steroidogenic pathway. Now, after this, if we follow this pathway, if we have palpable gonads, if we have Mullerian structures, here we had no Mullerian structures, we have an XY-DSD. So we look for testosterone levels. Testosterone levels were low. Is there any salt wasting? So we do have salt wasting. We have hyponatremia, hyperkalemia, 17 OHP is high. So we do get salt wasting scenarios over here, STAR, POR, 3-beta HSD. A good test in this situation would be DHES levels to see whether it is raised or low. And in this situation, can we go to the next slide then? What came out of it? So DHES levels would have been high in this situation. And then again, the question of gender of hearing it's not something that we can just pinpoint and say at the moment. It requires pediatric endocrinology, urology, psychology support. and it's of course parental discussion at that point. So again, considering all of that, we need to think of gender rearing rather than a stat discussion like this, like that. Yeah.
Scenario in that you have got peripheral conversion to testosterone, so you will have some testosterone which is there. It's not good enough to cause virilization in a boy, but it's good enough to cause virilization in a girl. So generally, Dr. Pratik, we talk about when we say you have a XY-TH, we generally say, okay, you go for a female gender of feeling, but 3-beta-HSD could be a complicated thing.
Yeah.
Because your androgen levels may be reasonably high from that
Yeah.
perspective. The other thing I wanted to discuss with you is about the DHEAS level. So we do see the DHEAS levels are usually very high in most infants because of the effect of the fetal adrenal being there and more starvation happening. So what do you think would be the assessment? Because we have seen many cases of 5-alpha reductase and partial AIs who have a high DHEAS. So what is the major role of DHEAS here?
So I can't hear. Yeah. So
what is the major role of DHEAS here, do you think, in this setting?
So it's basically to know if it's an adrenal production of testosterone, and then that if there's a block there, we can get high levels of that.
So I would say that from my perspective, low DHEAS is more important. If your DHEAS is low, you have a very proximal defect. But
Yeah.
if you have a high DHEAS, it may be non-conclusive.
Yes.
17 OHPs and other things become normal and important from that regards. But this is a very valid point about gender of rearing.
Thank you, sir. So, gonads with no uterus, suggestive of XY-DSD, and in this case, salt wasting along with high 17 OHP was suggestive of 3-beta-HSD defect. Moving to the next case, 14-day-old child was brought with the concern of DSD. Here the picture is shown. There was asymmetrical genitalia with right side testis was present, and on doing ultrasound, uterus was present. Dr. Yasmin, ma'am, your approach to the case?
Thank you. It's a very nice case. You can see there is a asymmetrical genitalia, and we have to search for the Mullerian structure clinically or by doing simple ultrasound, pelvic ultrasound showing here uterus is absent. Then we can consider it's a case of ovotesticular DSD. So we should also advise for a karyotype, and you can say that in this case you can ensure that is fit-free metaphase plates accuracy and rules out the mosaicism, and also we can advise for a fish also for a rapid test to quicker preliminary confirmation of chromosome before getting the reports of that sex chromatid abnormalities. If you look at the flow chart, you can see that when we will get a case of palpable gonad, then as we have to look for the Mullerian structure. If you compare with the previous case, you can see that the difference between here is that the presence of Mullerian structure, then we have to look for the AMH also. If it is low, then we can consider it's a case of either amenorrhea or dysgenesis. If it is high, then we can consider it's a case of AMH resistance. Then in this case, it's completely a case of ovotesticular DSD.
Thank you, ma'am. Your key messages, ma'am?
Key message is that when you will get a gonad with uterus, then we have to consider it's a case of ovotesticular DSD. And that means when you will get asymmetrical genitalia, either XX or XY DSD should be in your consideration.
I think ovotesticular DSD is a very, very complicated scenario where a lot of issues are there. One issue which we want to maybe discuss is when should we consider gonadectomy in these settings, Dr. Yasmin?
In this case, when we'll think about because there is chance of malignancy is more, that's why as we should advise and sex before that we have to think about the sex rearing also, and then we can advise the patient for the gonadectomy.
So definitely why
early.
It is a very, very clear-cut marker that you have to worry about that. And except for, let's say, androgen insensitivity where the testosterone is not in the bias, treatments are okay. But if you have a dysgenesis, removing that becomes very, very important. Very nicely pointed out by Dr. Yasmin.
Thank you, ma'am. Moving to the next case, 15-year-old girl presented with the complaint of delayed puberty. On examining, there was inguinal gonads. There was no Mullerian structures. And Dr. Dhwani, ma'am, what will be your approach to the case?
So like I pointed out earlier, if you have a girl with delayed puberty, primary amenorrhea, do have a suspicion for this being a DSD. And when you do your sexual maturity rating, or when you examine for your breast and pubic hair, do palpate for presence of inguinal gonads, as was done very rightly in this child. So you had a girl, 15-year-old girl with delayed puberty with presence of gonad and no Mullerian structure. So we're dealing with an XY DSD. Again, I want to know the electrolyte and androgen levels here.
So, ma'am, there was potassium was 3.2, and there was hypertension present in the child, and testosterone levels were low.
Again, classical of 17 hydroxylase deficiency. So do measure BP. And FSH levels, again, 120 say that your Sertoli cell function is gone, and the child may never be able to have a biological offspring. But yeah, your diagnosis here is 17 OHD deficiency.
Your key messages, ma'am?
So consider DSD in a child with primary amenorrhea, regardless of whether or not you have breast development. Monitor BP. It could, if you have hypertension, it could either be Turner or you can have 17 hydroxylase deficiency. So in a child with primary amenorrhea, always measure your BP. Look for, palpate for inguinal labial gonads.
So in this regard, often that hypertension will improve once you give steroids. If it's persisting, what would be your treatment of choice? You will just call Dr. Gani here.
The
hypertension, if it is persisting,
you will need to give. I'm sorry.
blockers like
Yes.
That will be there.
Thank you, ma'am. 12-year-old boy presented with the complaint of hematuria. On examining, there were no gonads palpable. Dr. Varsha, ma'am, how will you approach this case?
Okay. So, with no palpable gonad, actually, most of the time, DSTs, it is thought that it's always in the infantile, but late onset, if boy having hematuria or girl with primary amenorrhea, they should also be thought for the DST. So, no gonads. I would like to know about the Mullerian structures.
Mullerian structure was present, ma'am.
Okay. Karyotyping?
46XX.
Okay, so with this all scenario, either we are dealing with CH variants like 11 hydroxylase. I would like to know about the potassium and DOC levels of the child.
Potassium was on the lower side, and there was hypertension along with it. And DOC.
Okay, so with the huge virilization and later on said this hematuria, which is actually the menstrual blood that is coming in the form of urine. So it seems to be the case of 11 hydroxylase deficiency.
Very rightly said, ma'am. Gender of rearing in this case, ma'am?
Gender of rearing at this stage, again, it's very controversial, but with this at this stage, 12-year of child always being reared as a boy, social and psychological factors come into the play. Most of the time with all the keeping in view multidisciplinary approach, keeping all in the loop, psychologists, everything, most of the cases at this stage are reared as boy because chopping off such huge penis is also not possible at this stage. But again, all the factors come in the play.
Your key messages with this.
Yes, my key messages are that DST is always not in the infantile age group. Later onset, phenotypically female with primary amenorrhea. Think about DST. Phenotypically male with hematuria, which could be the menstrual blood. Think of the DST. And XX DST with hypertension is 11 hydroxylase.
Thank you, ma'am. So XX DSD with hypertension is 11 hydroxylase, and XY DSD with hypertension makes the diagnosis of 17 hydroxylase deficiency.
17, exactly.
Moving to the next case, 15-year-old girl presented to the OPD with complaint of primary amenorrhea. Height was 154 centimeter, weight was 48 kg. Stage was 4, pubic hair was stage 2, inguinal gonads were palpable here. Dr. Prateek sir, your approach to the case?
Yes, thank you. So we have a 15-year-old girl who's of average height, average weight, who's had breast development, pubic hair development, and there's gonads being palpable. So now if we go by, let's evaluate further. First, we get an ultrasound done, and the ultrasound shows an absent uterus. Next step, karyotype is showing XY. So at some point, we have AMH, which has worked, and we have testosterone, which is not working. So what we find is then when we do the testosterone, it is very high. So at a point, we have testosterone, which is the bodies which is resistant to testosterone, and the diagnosis is pretty clear cut from here. We have an insensitivity to testosterone, The testosterone to DHT ratio less than 10 means that it is being converted to DHT, so the receptors are not working, suggestive of a complete AIS. Yeah.
Thank you,
So
sir.
in this situation, again, gender of hearing, here it is quite clear-cut. The girl has been raised as a girl. We don't have to consider the gender. We need to have a very clear-cut discussion with the girl about fertility and further issues, which is very important in this situation.
Thank you, sir.
Also, to complete AIS, because the androgens were not working, they will not have an issue in terms of the virilization in the antenatal period. So, better to go ahead with a female gender feeling. The main question would be, when should we do a gonadectomy, doctor?
In this situation, so again, it is quite controversial. Again, the pros, there's discussion about, consideration of gonadectomy, considering the risk of malignancy, but there's been situations where individuals have wanted to, because of the aromatization, they have wanted to keep the gonads. So again, it is a discussion to be held.
So the key messages in this case was primary amenorrhea with pubarchy and breast stage development of 3 or 4 is suggestive of AIS, and they feminize during puberty.
Yeah.
Moving to the next case, a 10-year-old girl with clitoral enlargement, phallic length was 2.2 centimeter, bilateral gonads were palpable. Dr. Yasmin ma'am, how will you approach this case?
Thank you. Again, there's a very nice case that's with bilateral gonads with phallic length. Then we have to again look for the Mullerian structure in this case also. As you can see in the flowchart, there's the girl having no uterus. So, and the karyotype is 46XY. Then we have to go for the testosterone level.
The testosterone.
Testosterone level, as it's a high, then we can consider for the dihydrotestosterone level. It's showing that's low, then we can consider it's a case of 5-alpha reductase deficiency.
The gender of rearing.
So in this case, as the patients will get in puberty, the virilization will develop, then it can be considered this case as a case of male, as a sex rearing.
So in this case, because the issue is not action of testosterone, it is a conversion to DHT. Usually in the antenatal period, the DHT would have been very high. And they will have very high testosterone DHT during the testosterone at the level of the mini puberty. So they will virilize from that perspective. So this is something in which male gender feeling is often what is recommended.
Thank you, ma'am.
So I think I'd like to thank Dr. Nimisha for really going through this wonderful discussion. And I'll now just request Bhani to tell us a bit about the DSD interpreter, which we have developed and how it works on that. Because a lot of us, when we talk about these lectures, it becomes easy. But when you really see a patient, it often becomes very difficult to interpret it. And if you look at the algorithm, which is here, most people will stop thinking once they see the algorithm and they go forward from there. So Dhwani, what exactly did we do and what did we find in that regards?
Thank you so much, sir. So what we have done here is taken a sequential evaluation wherein you look into the clinical parameters and key lab investigation, that is your electrolytes and basic hormonal levels, and do it stepwise so that you don't run a huge battery of tests for the patient. So that is how, let me show you and our application has shown a concordance that is at par with the experts and is expected to truly help out pediatricians, neonatologists, and pediatric trainee when dealing with children with atypical genitalia. So this is our MedEClasses app wherein we have the DSD interpreter. It says if you have palpable gonad, yes, no Mullerian structures. It prompts you to enter the electrolyte and testosterone value. So you can see that here you have salt wasting and it gives you a diagnosis. It gives you the diagnosis. It asks you what to do next. So consider karyotype and genetic study and follow-up approach to be done next. If you have no palpable gonads and Mullerian structure, then you're dealing with an XX DSD. It asks for maternal virilization. It asks you for the 17 OHP and electrolyte levels. And what it does here is it analyzes. It tells you this is likely salt wasting, adrenal insufficiency. Start your steroids. Consider a female gender of rearing and monitor 17 OHP levels and electrolytes. So not only does it give you a diagnosis, it tells you what treatment needs to be started and what needs to be monitored and follow up. It also gives a guidance on the gender of rearing, which is again not hard and fast, but something to be considered. Last up, we have child with, let us see what input start here. Palpable gonads as well as Mullerian structures. So it asks for your genital symmetry and AMH levels, based on which it makes the diagnosis of ovotesticular DSD. Now it tells you what kind of karyotype needs to be done. So it says 50 metaphase karyotype, and go for a genetic study preferably.
And this interpreter, the main feature that we have tried to develop is to do a sequential approach in terms of workup and not all the workup at a time. So even with XYDSD, we're not telling you to do testo, DHT and all the investigation in one go. You go step by step. So this will provide us a cost-effective way.